Dr. Valentino to the OR, please. Dr.
Certainly.
Valentino to the OR.
Let's explore decompensated cirrhosis in more detail, focusing on its pathophysiology, advanced diagnostic techniques, comprehensive management strategies, specific case studies, psychosocial impacts, recent research developments, and public health implications. Chronic liver disease progression. Cirrhosis development. Chronic liver damage leads to fibrosis, which disrupts the normal architecture of the liver. This can result from various conditions, including chronic viral hepatitis B and C, alcoholic liver disease, non-alcoholic fatty liver disease, autoimmune hepatitis, and hemochromatosis or iron overload. Mechanisms of decompensation. Portal hypertension. Increased resistance to blood flow in the portal vein due to fibrosis and regenerative nodules. This leads to varices, which are dilated veins in the esophagus and stomach that can rupture, and ascites, which is fluid accumulation in the abdominal cavity due to increased pressure in the portal system. Hepatic insufficiency. Loss of hepatocyte function leads to several issues. Coagulation factor deficiency results in an increased bleeding tendency due to reduced production of clotting factors. Hypoalbuminemia, which is decreased albumin, leads to fluid shifts and edema. Impaired metabolism causes difficulty in metabolizing drugs, toxins, and waste products, leading to complications such as hepatic encephalopathy. Chronic inflammation can lead to further liver damage and complications, including infection and systemic inflammatory response syndrome, or SIRS. Gather information on alcohol use, viral hepatitis history, medication use, and family history of liver disease. Symptoms of liver dysfunction, for example, jaundice, pruritus, and fatigue, should be noted. Assess for signs of liver disease. Jaundice indicates bilirubin accumulation. Spider angiomata and palmar erythema are signs of estrogen excess due to liver dysfunction. Ascites and edema are physical signs of fluid retention. Liver function tests include serum aminotransferases, AST and ALT, which are elevated in liver injury. However, levels may be normal in cirrhosis. Alkaline phosphatase, ALP, and bilirubin are elevated in cholestatic liver disease and cirrhosis. Prolonged prothrombin time, PT, and INR indicate impaired liver synthetic function. Creatinine and BUN assess for renal impairment, which can occur in decompensated cirrhosis. Imaging studies. Abdominal ultrasound. It's a non-invasive method to assess liver size, echogenicity, and the presence of ascites or masses. Doppler ultrasound can, evaluate portal vein flow and detect portal hypertension. CT scan and MRI. These provide detailed images of liver structure and can identify complications such as hepatocellular carcinoma or biliary obstruction. Endoscopy, esophagogastroduodenoscopy, or EGD, is used to assess for varices and potential bleeding sources, with therapeutic intervention as needed. Initial management: hospitalization. This is often required for patients with decompensated cirrhosis to monitor for complications and initiate treatment. Fluid management. Fluid resuscitation involves administering IV fluids judiciously while monitoring for signs of fluid overload, particularly in patients with heart failure or significant ascites. Nutritional support, dietary modifications. It's important to encourage a balanced diet with adequate protein, unless hepatic encephalopathy is present, and sodium restriction to manage ascites. Ascites management. Diuretics like spironolactone and furosemide may be used to promote fluid excretion. Paracentesis involves the therapeutic drainage of acidic fluid for symptomatic relief, or if infected, such as in cases of spontaneous bacterial peritonitis. Variceal bleeding requires acute management, which typically involves the use of intravenous octreotide and balloon tamponade to control the bleeding immediately. For secondary prevention, band ligation during endoscopy and long-term beta-blocker therapy are employed to prevent rebleeding. Now moving on to hepatic encephalopathy, lactulose is administered to reduce ammonia absorption in the gut. Additionally, rifaximin, a non-absorbable antibiotic, helps reduce gut bacteria that produce ammonia. Long-term management and follow-up are crucial aspects of care. Liver transplantation becomes a consideration for patients with decompensated cirrhosis, particularly those whose model for end-stage liver disease, or MELD score, indicates a poor prognosis. The pre-transplant evaluation is comprehensive, including psychological evaluation, nutritional status, and social support systems. Regular monitoring is essential, with follow-up appointments to keep track of liver function, manage complications, and check for signs of hepatocellular carcinoma. Psychosocial aspects. Impact on quality of life. Emotional distress. Living with chronic liver disease can lead to anxiety and depression, necessitating psychological support. Support systems. Family involvement and support groups can significantly enhance coping mechanisms and improve adherence to treatment. Research and future directions. Emerging biomarkers. Research is ongoing to identify biomarkers that can help predict liver disease progression and the risk of complications. Innovative therapies. New pharmacologic agents targeting the underlying mechanisms of liver disease, such as antifibrotic drugs to prevent progression to cirrhosis. Telemedicine. Utilization of telehealth for follow-up care, especially for patients in remote areas, can improve access to specialists and enhance management. Public health considerations. Awareness campaigns. Initiatives to educate the public about liver health, the risks associated with alcohol consumption, and the importance of vaccination against hepatitis. Screening programs. Implementing routine screening for populations at risk for liver disease, including those with hepatitis or heavy alcohol use, to facilitate early detection and management. Conclusion. Decompensated cirrhosis is a complex condition that poses significant challenges for patients and healthcare providers alike. Through comprehensive management strategies, ongoing research, and public health initiatives, we can improve outcomes and quality of life for individuals affected by this serious condition. If you have specific questions or would like to explore additional aspects further, please let me know.